Welcome back to the deep dive. If you're listening to this, chances are you are deep in the trenches of revision. You might be just weeks away from the FRCS, and the pressure is on. We've been there.
We definitely have. And that's the goal today, isn't it? To just cut through the noise. This isn't a textbook reading. We're zeroing in on the high-yield stuff the clinical pearls examiners love to ask about.
Exactly. We're tackling an absolute staple of head and neck surgery, salivary gland tumors. We're going to cover everything from the rule of 80s right through to the specifics of a Blair incision.
It's a huge topic, but it's one where a really structured approach will save you. If you have the classification down, you can handle almost anything they throw at you.
Before we jump in, just two very quick things. First, if these deep dives are helping you, please take a second to rate the show and maybe drop a comment. Suggest the next topic you're stressing about.
We actually do read those, and it helps us decide what to cover next.
Second, and this is important, if you want our specialized journal club and clinical cases sessions, where we get into the really complex stuff, you need to sign up for the premium subscription.
Right. That's where we move from just knowing the facts to, applying clinical judgment.
All right, let's get into it. We're going to run this like a Viva. Rapid fire questions and explanations.
Let's do it.
Okay, let's start at the beginning. Epidemiology. Every resident knows the rule of 80s, but what's the actual nuance we need to understand?
Right, so this is the classic framework. First off, salivary tumors aren't super common, only about 3% of head and neck neoplasms. But within that, the rule of 80s gives us the distribution.
So 80% are in the parotid.
Exactly. 80% occur in the parotid gland. And then of those carotid masses, another 80% are benign.
Which is reassuring, statistically speaking. A parotid lump, odds are it's benign.
It is, but that's the classic exam trap. You can't get complacent because the moment you leave the parotid, the statistics completely flip. It's the inverse relation principle.
Meaning the smaller the gland?
The greater the chance of malignancy. It skyrockets.
So let's put numbers on that. What about the submandibular gland?
It drops off a cliff. For the submandibular gland, only about 50% of tumors are benign. So it's basically a coin toss.
50-50. And for the really small glands, sublingual, the minor glands?
That's the real danger zone. Only 20% of those are benign, which means 80% are malignant.
Wow. So a lump in the floor of the mouth is, by default, suspicious?
Highly suspicious.
Mm-hmm.
In the parotid, you assume benign until proven otherwise. In the minor glands, you have to assume malignant.
Okay, let's talk clinical signs. Location first. A lump on the face.
Parotid. Angle of the mandible is usually the parotid tail, but a big submandibular can present there. In the neck, it's submandibular. Floor of the mouth.
Sublingual. Got it. Now, what features scream malignant versus benign on examination?
Benign tumors are, polite. They're slow-growing, painless, mobile. Malignant tumors are aggressive, so you're looking for pain, rapid growth, fixation. But the number one red flag.
Has to be the facial nerve.
A facial nerve palsy with a parotid mass is cancer until you prove it's not, period. Benign tumors just don't do that. You also look for skin invasion, bleeding from the duct, things like that.
Right. So let's dive into the pathology. The big two benign tumors. Let's start with the most common one. Pleomorphic adenoma. What are the key facts?
Okay, pleomorphic adenoma, or benign mixed tumor. This is the big one. It's about 85% of all salivary neoplasms, 70% of parotid tumors.
And who gets them?
Tends to be females, about twice as often as males, usually third to sixth decades. And they love the tail of the superficial lobe.
Now, here's the crucial surgical point. They look encapsulated. Why is just shelling one out enucleation such a bad idea?
That is the enucleation trap. It's
Yeah.
a classic mistake. To the naked eye, it looks like it has a perfect capsule.
Mhm.
But it's a false capsule.
What's happening microscopically?
The tumor has these little finger-like projections, pseudopodia, that poke through that capsule. So if you just shell it
So
out,
you're cutting right through them.
you're cutting through them and leaving tumor cells all over the surgical bed.
And that leads to a nightmare recurrence.
A multifocal recurrence, little seeds of tumor everywhere. That's why the standard of care is a superficial parodectomy. You need that cuff of normal tissue.
And what if you just leave it? Is there a risk?
There is. Malignant transformation happens in up to 10% of cases. It becomes a carcinoma ex pleomorphic adenoma.
Which is nasty.
Extremely nasty.
Okay, number 2 on the benign list, Warthin's tumor. How is this different?
Warthin's is interesting. It's about 15% of tumors, almost exclusively found in the parotid. And the demographics flip completely.
So, more common in men.
A huge male preponderance, like 5-to-1, usually older men. And it's strongly associated with smoking.
The smoker's tumor.
That's the one. And the other Key exam fact is that 10% are bilateral. So if you have an older male smoker with lumps in both parotids, you should be thinking Warthin's.
Treatment is still a superficial paroidectomy.
Yes, same surgical principle.
Let's switch gears to malignancies. What's the most common malignant salivary tumor we see?
That would be mucoepidermoid carcinoma. Makes up about 30% of malignant parotid tumors.
And with this one, the grade is everything, right?
It's critical. Grading dictates the entire prognosis. A low-grade mucoepidermoid is pretty indolent, at 86% 5-year survival.
At a high grade.
A totally different animal. It behaves like an aggressive squamous cell carcinoma. The 5-year survival plummets to just 22%.
So for high grade, you have to be thinking about the neck.
Absolutely. Nodal involvement is common. You're almost certainly doing a neck dissection and adding adjuvant radiotherapy.
All right, let's talk about the one that I think gives surgeons the most anxiety. Adenoid cystic carcinoma. What makes it so notorious?
Adenoid cystic. It's the most common malignancy in the submandibular and minor glands. Its calling card is perineural spread.
It travels along the nerves like a highway.
Exactly. And that's what leads to skip lesions. You could think you have clear margins on the main tumor, but they're cancer cells tracking way up the facial nerve, far from where you cut.
Which makes long-term prognosis tricky.
It's described as indolent but relentless. The 5-year survival stats can look deceptively good, but the recurrences and the lung mets, they often show up 10, 15, even 20 years later.
So a 5-year all clear doesn't mean much.
It's unreliable.
Yeah.
The treatment has to be the widest possible excision you can get, plus adjuvant radiotherapy, almost always.
Just a quick hit on actinic cell carcinoma.
Actinic cell is, relatively speaking, one of the better ones, usually low grade. You're looking at a 90% 5-year survival. Total paroidectomy is often curative.
And malignant mixed tumors.
That's the carcinoma X pleomorphic adenoma we mentioned. High grade, spreads through the blood, very poor prognosis, needs radical surgery and radiation.
Okay, let's move to the workup. Patients in your clinic. What's the gold standard for a tissue diagnosis?
FNAC, fine needle aspiration cytology.
And its accuracy.
In good hands, it's about 90% accurate for telling benign from malignant.
Now, here's the classic Viva question that always trips people up. Is there ever a role for an open biopsy of a major salivary gland?
No.
Say it again for the people in the back.
The answer is an emphatic no. You avoid open biopsy at all costs. The risk of tumor seeding is just too high. You cut into a pleomorphic adenoma, you've just contaminated the entire field.
You've guaranteed a recurrence.
A much more difficult multifocal recurrence. It's either FNAC or a formal excisional biopsy, which is the paroidectomy itself.
What about imaging?
Ultrasound is great for guiding the FNAC, but for surgical planning, you really need a CT or an MRI to see the anatomy, especially any deep lobe involvement.
And what about frozen sections during the operation?
They're not great for a primary diagnosis. Salivary pathology is too complex for that, but they can be very useful for checking if your surgical margins are clear.
Okay, let's get into the OR, the Viva on surgical technique. You're doing a superficial paroidectomy. First, what's your instruction to the anesthetist?
Please, no neuromuscular blockers, no paralysis.
Because you need the nerve stimulator.
Exactly. I need to be able to find the nerve. If the patient is paralyzed, the stimulator is useless and the operation becomes incredibly dangerous.
Okay, describe the Blair incision.
It starts up in the preauricular crease, just in front of the ear. You follow that down, curve back under the earlobe towards the mastoid, and then sweep forward into a neck crease.
How far down in the neck?
About 2 finger breadths below the mandible to keep the marginal mandibular nerve safe.
All right, the big moment. You're looking for the facial nerve. What's your primary landmark for the antegrade approach?
The tragal pointer, that little piece of cartilage on the ear canal. It points you in the right direction.
And where is the nerve in relation to it?
The main trunk is about 1 centimeter deep and just slightly anteroinferior to that point.
Once you find it, what's the dissection technique?
You gently spread along the perineural plane. You're essentially peeling the superficial lobe off the nerve and its branches, working from the trunk outwards.
Okay, but what if there's a huge tumor blocking the trunk? You have to go retrograde. What are your distal landmarks?
This is your bailout plan. You can find the cervical branch down by the retromandibular vein, or the marginal mandibular branch where it crosses the facial artery.
And the buccal branch.
The buccal branch runs right alongside the parotid or Stenson's duct. That's a very reliable landmark.
Let's talk about the difference between a total and a radical parotidectomy.
So a cold parotidectomy means you're taking out the superficial and the deep lobes, but you're preserving the facial nerve. You sort of tease the deep lobe out from between the nerve branches.
And radical means?
Radical implies sacrifice. It means the tumor is stuck to the nerve, and you have to deliberately cut the nerve to get the cancer out. You tag the ends for a nerve graft later.
Okay, surgery's over. Let's talk complications. The classic one is Frey's syndrome. What is it?
Frey's is gustatory sweating. The patient eats, and their cheek sweats.
What on earth is going on there?
It's aberrant reinnervation. The parasympathetic nerves that used to tell the gland to make saliva get confused during healing. They regrow and accidentally connect to the sweat glands in the skin.
So the signal for salivate becomes a signal for sweat.
Precisely.
And how do we prevent it?
You need a barrier between the raw parotid bed and the skin. You can use a bit of the SMAS layer, a flap of sternocleidomastoid muscle, or an acellular dermal matrix.
What about the numb earlobe patients always complain about?
That's from injury to the great auricular nerve. It's almost unavoidable as it runs right across your field. You warn the patient about it beforehand.
Okay, so just to recap, we've hit the rule of 80s, the enucleation trap, the sneaky behavior of adenoid cystic, and the critical landmarks for a safe parotidectomy.
It's a lot, but it all comes back to the anatomy. If you know where the nerve is and you understand the tumor's behavior, the decisions start to make sense.
What's one final thought for our listeners to take away?
I'd say remember that with salivary cancers, the clinical behavior often matters more than the histology report. A tumor like adenoid cystic might look low-grade, but clinically, it's relentless. Treat the patient, not just the slide.
Powerful advice. Well, that brings us to the end of this deep dive. If this was useful for your revision, please go rate the show. It really helps other residents find us.
And remember, the premium feed has our clinical case and journal club episodes. That's where we apply all this to real-world scenarios.
Thanks for listening. Good luck with the exams, and we'll see you on the next deep dive.
Take care.